You're listening to Just Medicine, an equity in healthcare podcast created by medical students in British Columbia.
Hello, everyone, and welcome back to the Just Medicine podcast. It's great to have you back, and I hope you're all having a lovely start to your March. So you may have heard me before. My name is Annie, and I'm a medical student at UBC. I'm recording a series on reproductive health, so this is the second part in that series. The first episode was on access to contraception, and I really enjoyed that conversation, so go give it a listen if you're interested. But today we're talking about something different, and something really important, which is cervical cancer. And in my very unbiased opinion, it turned out to be a really interesting and just a great conversation. So I hope you like it as much as I did. So just to give a little bit of an introduction to the topic, cervical cancer is unique because it's almost entirely preventable when the right measures are taken. We have a really effective vaccine against the virus that causes almost all the cases of cervical cancer. We also have really good screening methods, and if it's caught early on enough as a precancer, it also has really good treatment outcomes. But it's also a classic example of a health equity issue, and it's rooted in things like public health, because not everybody has equitable access to the things I just mentioned for a variety of reasons. However, the fact that we do have these proven strategies for preventing cervical cancer, which is a devastating disease, from even occurring in the first place is super cool and also very hopeful. So I think we should all get talking about this topic more, which is why I chose it for this podcast. But before we get into all of that, I would love to introduce today's lovely guest speaker, who is so passionate, knowledgeable, and articulate about the topic at hand. I think you'll really enjoy listening to her speak. Dr. Lauren Adolph is a gynecologic oncologist in Moncton, New Brunswick at the Dr. Leon Richard Oncology Center. Dr. Adolph majored in human physiology in her undergraduate studies at UBC, and then she stayed at UBC to complete her medical degree training there. Moving from one coast to another, she then completed her residency training in OBGYN, or obstetrics and gynecology, at Dalhousie University in Halifax, and after that, she completed her fellowship training in gynecologic oncology at the University of Manitoba in Winnipeg. Dr. Adolph is in the early days of her career, and with her newfound time after the completion of her medical training, she is also beginning to take up fun new hobbies like squash, yoga, and ballroom dancing. Okay, so I've got Lauren on the podcast now. Hey, Lauren.
Hi.
So before we talk about the topic and really get into the nitty-gritty, I'd love to hear more about your work, what you like about it, and just sort of what led you there.
Yeah. So, as you kind of said at the beginning, I'm a gynecologic oncologist in Moncton, New Brunswick. Gynecologic oncology is a mouthful, and my husband likes to tease that we have bad marketing because people tend to stop listening after the word gynecologic. But what I really am is a mixture of a gynecologist and an oncologist. So that means I did med school. I went to med school at UBC, and then I did a residency in OBGYN, and then I discovered my love for oncology and women's cancer. And so I did 2 more years of a fellowship in gynecologic oncology. Now I'm working, like I said, in Moncton, New Brunswick, at a smaller hospital with a group of 4 women. There's a group of 4 of us that share this territory, and it's lovely to work with 4 women. And I just started here, I should say. I just started in November. So I just finished my fellowship last fall. What led me here? Like I said, when I was in medical school, I really loved surgery, to be honest. I loved hands-on things, doing things with my hands and feeling the immediate reward or immediate feedback of doing something with my hands. And turns out I was pretty okay at that. So I got into OBGYN, delivering babies and doing surgery, and that was all really exciting. And then one day I discovered that the surgery involved in women's cancers was complex and rewarding and challenging, and I liked that a lot. We do a lot of surgery in my subspecialty, and I really like that. But the other aspect of it is often a gynecologic oncologist's job description includes following women from what I like to say, from diagnosis to death. So diagnosis of their cancer all the way until I discharge them from my clinic, or they pass away, and that happens with cancer. But I find it a huge privilege to be a part of women and women's families' lives in that very emotional and intense time when you're diagnosed with a cancer and dealing with a cancer, and going through treatment. So seeing that huge privilege when I was going through my training was partially what drew me towards gynae oncology, and has kept me going. It's really rewarding to work with these women, despite what they go through. And I hope they feel that kind of back through my care, that they know that I care about them, and it's a big reward to take care of them. So that's what led me here, and certainly those pillars of what I've loved about it have held true all the way through my training and now into my job. And yeah, so that's a little bit about me.
Amazing. Thanks, Lauren. I'm wondering, I think a lot of people, when they hear that you work in oncology, they might think that that's really heavy and wonder how you deal with it emotionally. You don't always have good outcomes, or maybe you would say it's still a good outcome if, you help someone live a long, comfortable life. But I
Yeah.
was wondering how you deal with the emotional load of working in oncology.
Yeah, for sure. A good question. Yeah, I think it's not for everyone. I'll say that at the outset. I don't know, you have to have a certain understanding, a certain willingness to go through that heaviness at first, for sure. And then, like you said, you have to have some, well, as you alluded to, you have to have some resilience or some ways to deal with that on your own. I think, viewing it, like I mentioned already, viewing it as a privilege to stand alongside these women. You're not in their lives. You're not experiencing it yourself. It's not your family who's going through it, but you're standing alongside them as they go through this. So keeping that little bit of difference helps me, because it helps me stay truly empathetic, but not sympathetic, if you can understand my difference. Which I think helps, because patients don't want you to break down in front of them either. They need you to be their doctor who's there to support them and be strong alongside them. So that's one thing. And then for me personally, I think having outlets outside of work, talking about things, my loved ones in my life, being able to confide in them and talk to them about a heavy day or a challenge or whatever, having that safe outlet, whether it's my loved ones or my colleagues. My colleagues are a big help as well. And then you build resilience outside of work by doing things that are completely different. Like my husband and I just took up squash, so coming home and being like, I guess I can't dwell on whatever happened at work too much longer, because we gotta go play squash. Stuff like that. I think it's a big balance, and you build up a network of resiliency and people around you. But yeah, there's no denying that it's heavy. But it is what I love. So
yeah, it sounds like you've done a really good job of trying to create balance, and it's nice that you have a good support system. And I'm sure, as heavy as it can be too, it's really rewarding, as you mentioned, getting to go through that and to have those longer term relationships with patients.
Yeah.
Yeah. Great. So thanks for sharing. I was wondering if you could give us a brief introduction into the topic. So today we're talking about pap smears, HPV screening, cervical cancer, the whole deal. But it's not just a medical issue, and I think that's something that not everybody knows about or realizes. It's actually really rooted in inequity. So I was wondering if you could give us a little preview as to why that is.
Yeah, for sure. So cervical cancer is one of the cancers that I deal with. So I guess I didn't specify. I take care of kind of how I generally describe it is women's cancer below the belt. So I don't take care of breast cancer, but all other women-specific cancer, of which cervix is one of them. So yeah, cervical cancer definitely has a special place in my heart. It is a unique cancer. It's caused by 99% of it, I should say, is caused by the HPV virus. And so that makes it a attackable cancer from a public health point of view and a prevention point of view. So we're going to get into this, but cervical cancer basically is a preventable disease most of the time. And we'll talk about how and why and when and all those goodies. But health equity plays a massive role in putting up barriers to women or people with cervixes obtaining prevention for this disease. And that's really, really breaks my heart when I know that I don't actually, I could envision a world one day where I wouldn't see these patients in my clinic when it's a devastating disease that sometimes we can cure, but sometimes we can't. So yes, yeah, health equity really plays the majority of the role of the root of this problem.
Yeah, for sure. And it's both, like you said, it's devastating because you're seeing these cases of cervical cancer when they could have most likely been prevented or caught early enough and treated well and treated successfully. But also on the flip side, it's kind of hopeful because there are things we can do. And if we can actually move forward and improve our prevention or preventative measures and make that more widespread, there is hope that it could maybe even be eradicated.
Yeah, I love that word. It sounds like a lofty goal, but many, and I think you're gonna tell me all about it, but many many health organizations around the world and Canada have declared that a possibility. And so why not follow in their awesome words?
Yeah, for sure. So yeah, let's get into it. So regarding health equity, we've been talking about how cervical cancer is a health equity issue. When you look at the studies, most cases of cervical cancer are happening in lower to middle income countries. And that has to do with a variety of things. The World Health Organization has really set it out really well. They've created some goals based on a few pillars that we'll mention. But the gist of it is most people who are getting cervical cancer are in lower to middle income countries and are disadvantaged socioeconomically, and there are some really disproportionate impacts to certain populations. So I think we'll start from more of a global perspective, and then we'll move more Canada specific.
Sounds good.
Yeah. All right. So the thing is, where we're at currently, too many women, particularly poor women, are dying of cervical cancer. And like we mentioned, the devastating part is that it's preventable and it's treatable. To give a stat on that, the World Health Organization had said that around 90% of deaths in 2018 from cervical cancer were in those lower income countries. And there's higher incidence and mortality, so worse outcomes for cervical cancer in countries that have worse national access to the preventative measures, which makes sense. So the vaccine and the screening programs, and then also the early treatment. So I think in order to understand the issue, it's also important to talk about how cervical cancer occurs. And I know you mentioned that 99% of cases are caused by the HPV virus, but not everyone's bodies deals with the virus in the same way. So from my understanding, most people who contract HPV will fight it off themselves if they have a strong immune system. But other people may not. So I was wondering if you could speak to how an HPV infection might be dealt with differently in one person compared to another.
Yeah. So we can talk about HPV in different individuals, but we can also just talk about how does cervical cancer come about and why, and what does it look like and over what time period. So cervical cancer, like I mentioned, maybe I'm exaggerating, maybe it's 95% of cervical cancer is caused by the HPV virus, but a whole boatload of it. And it has what we say in medicine, a bimodal distribution. So cervical cancer is most commonly seen in those in their 30s and then those in their 60s. So there's a little bump in the 30s and bump in the 60s. And HPV, so the way cervical cancer comes about is HPV is contracted usually by sexual intercourse, but really mucus to mucus membrane contact of one individual having HPV, passing it to the next. The HPV virus then integrates into your cells and through a series of pathways starts to multiply and infect your cells of your mucous membrane. So HPV can actually cause cancer in your mouth, in your throat, in your head and neck, as well as in your genital region. It can cause genital warts on the outside of the vulva. It can cause vulvar cancer on the outside of the vulva. And I know we're not talking about that today, but just to get an idea. In men, it can cause penile cancer. And then, of course, in the upper genital tract, it can cause vaginal cancer or higher up cervical cancer. So cervix cancer, what we're talking about today, it's just more common. It happens at the transition zone of your squamocolumnar junction. So that's just fancy terms for when your cervix goes from having a skin-like appearance to the inside of your cervix, which has a glandular appearance. And it's at that transition zone that the HPV virus likes to infect the cervix, and then it likes to transform those cells into dysplastic cells. So that's a fancy term for precancer or pre-invasive disease. And it goes over this grumbling period of having precancer, pre-invasive disease, and that period of time can be up to 15 years of grumbling along, of not a very weird looking cell to a very weird looking cell to an invasive cell and cancer. And so it's this precancerous period that gives cervical cancer this unique opportunity to be screened and prevented. So that's what causes cervical cancer. And then it grows just like any other cancer and starts to spread throughout the body and et cetera, et cetera. So the HPV virus, there are a bajillion strains, to use a technical number, of HPV viruses that can cause cancer. We have identified many, many high-risk strains of HPV that are more likely to cause cancer. There's like 30 plus of those. And there's 2 strains of HPV that we know that cause genital warts, so precancer that isn't likely to turn into cancer. And how do we deal with those HPV infections differently? You're right. Young, healthy people, whatever strain of HPV they contract, they are likely to clear it on their own just by having a healthy immune system. And what do I mean by young people? Probably under 25, under 30. Those people are highly likely to clear that strain of HPV whenever they've been infected by it. After that age, you're less likely to clear that HPV infection. And then other risk factors for people who are unlikely to kill it with their own immune system are people who are immunocompromised themselves. So they've had a organ transplant and they're on immunosuppressive medications. They have other immunosuppressive autoimmune conditions, even things like Crohn's disease, autoimmune bowel disease, lupus, HIV, lots of other health conditions that can decrease your immune system's effectiveness. Those people almost certainly would not clear their HPV infection. So then we're left with, if they have an HPV infection and it's causing a precancer, how do we help them clear that precancer so that over that period of 15 years, it doesn't develop into a cancer? And that's really for people who do or don't have a good immune system, whatever the case may be, those are the group of people that we're trying to find with Pap screening or HPV screening, which we'll talk about both. We're trying to find those people, bring them to something called colposcopy, which we'll talk about, and do either surveillance or a small procedure to try and clear away those precancerous cells on the cervix to prevent the transition into actual invasive cancer and thus preventing the disease. So I don't know if that answers your question, but that's a little bit about HPV, the progression of cervical cancer, and how that whole shebang works.
No, that was great. That was a really good overview. So, in terms of preventing cervical cancer, like I mentioned earlier, the World Health Organization has created a global strategy for cervical cancer elimination. And I believe that was in 2020. And their goal is to eradicate cervical cancer. They have some specific numbers that they've calculated. So, in order to do that, they found there needs to be less than 4 per 100,000 women in all countries developing cervical cancer. And that depends on three different pillars. So the first pillar is vaccination against the HPVs. So their numbers there are they hope to have 90% of girls vaccinated by age 15. The second pillar is screening. So there's a couple ways to do screening, and we'll talk about that in a minute. So their goal there is 70% of women being screened by 35 and again by 45 years of age. And then the third pillar is treatment, of course. So 90% with pre-cancer being treated and 90% with 90% with invasive cancer being managed. So they call that their 90-70-90 target, and they're trying to achieve it by 2030 in order to eliminate cervical cancer within the next century. And to me, that sounds a bit ambitious. I don't know. What do you think about it?
Sure, it sounds ambitious because it sounds like 2030 is coming soon, but I think we already have some of those pillars in place, right? HPV vaccine is out there. It has excellent safety data. It has excellent efficacy data. It works. It's great. It's out there. We can give it to people. We just need to get it into the arms of more women, more people with cervixes across the globe. So I think it's not that far off. And same with the screening strategy. We have those even in less poor and middle income countries. We have screening strategies that can work. Yeah, it sounds ambitious, but it's already well on its way. So I like to stay the optimist. I mean, I'd love to see this goal achieved. This is a very, very worthwhile public health goal on a global stage.
Of course, yeah. So let's talk more about the details regarding those pillars. So, first of all, why don't we talk about the vaccines? So, could you give us, I know you're the expert here, could you give us an overview of the HPV vaccines?
Yeah, well, okay. So, yeah, you were talking about the pillars, and you're talking about the vaccine is primary prevention, screening, secondary prevention, and then treatment, right? So, yeah, first things first, primary prevention. Okay, so what do I know about the HPV vaccine? It's a vaccine against a virus just like every other vaccine, just like the COVID vaccine, just like the cold and flu, like the seasonal cold vaccine. It's a vaccine against a specific virus. I told you there was a bajillion strains of HPV, so the vaccine over these last years has tried to increase the number of HPV strains that it covers. I think I was 16 when my mom, when it first came out, and my mom insisted that I get vaccinated, which, bless her heart, thank you for doing that, Mom. And at that time, the Gardasil vaccine was the quadrivalent vaccine, so it only covered 4 strains of HPV: 6, 11, 16, and 18. 6 and 11 are the strains of HPV that cause genital warts but do not cause cancer. And 16 and 18 are the most high-risk HPV strains, and 16 is the most common HPV strain that causes cervical cancer. But luckily, Gardasil and our scientific community has become more awesome and has created the nanovalent Gardasil vaccine now, which is available, and that covers 9 strains of HPV. So that is what's being given out to grade 6 girls and boys, depending on what province you're in school. It's a 2 or 3 shot vaccine schedule. It depends on how old you are. If you're younger, so in grade 6, they only have to have 2 doses of the vaccine. That's because their immune system is like on fire in grade 6, and so they get the vaccine, and their body goes superpower against the HPV vaccine with only 2 doses. Whereas if you're a bit older, like I was when I got it, then I got 3 doses of the vaccine. So most provinces, I think now across Canada, it's available free for grade 6 students unless your parents opt out. And after that, you can certainly opt in later. And I mean, it's available to people all the way up to age, I think the cutoff is 49 or 47. It depends on your coverage in your province for the Gardasil vaccine, but certainly it's worthwhile getting, really, no matter how old you are, but the benefits are the greatest if you're young and receive the vaccine. So yeah, that's what I know about the vaccine. Oh, I guess I should tell you that it's wonderfully effective against preventing HPV if you have not been exposed to this one of the strains of the HPV virus that's in the vaccine already. And so that's the way that it prevents cervical cancer, because I already described to you how HPV infection progresses into cervical cancer. So if you're immune and you fight it off because you had your vaccine, then theoretically you should never experience cervical cancer in your life unless you get a very rare non-HPV related type of cervical cancer.
Awesome. Thanks. Yeah. So the HPV vaccine, I don't know what the statistic is, but it's super effective at preventing an infection. Yeah. I guess the only downside is if you don't get it, if your parents opt you out in grade 6, and you, at least in BC, if you don't start the course of your vaccine doses before age 19, you have to pay for it yourself. And that can get really expensive, especially without health insurance. Do you think that that's like a significant barrier or significant issue with regards to cervical cancer?
Yeah. I will say before I answer that question that it's 97% effective at preventing cervical cancer and cell changes that lead to cervical cancer.
Wow. Okay.
Vaccine. So very, very effective,
Yeah.
97%. And some of that dropped percentage point is going to be because a very small, rare proportion of cervical cancer is not HPV related, but so it's excellent at doing HPV prevention. Anyway, so to answer your question about a barrier, yes, I mean, certainly we could go on a whole tangent about how not having free access to drugs and vaccines in general in Canada is a barrier to health care and good health care, especially if people don't have insurance. And that problem only gets bigger if you go south of the border. But that aside, I think we should applaud Canada in a big way for delivering this vaccine free of charge to our young students in grade 6. But I think I also think we should applaud our healthcare system and our public health system for making it an opt-out program, because we know that opt-out programs for vaccines end up treating more children than opt-in programs. So that I think is great. Of course, I think parents have the right to opt out for whatever reason they see fit for their child. But I would highly encourage parents to do some research about the HPV vaccine and its safety and efficacy before they choose to opt out. Because I can't say enough good things, as you've already kind of heard me say. But yeah, a barrier to not having it covered after the age of 19, it certainly sucks. But I kind of understand why, because we are a publicly funded healthcare system. And so we're going for biggest bang for our buck, right? We're trying to deliver free healthcare in a manner that benefits the most people. And we know if you get the vaccine young, because you haven't been infected with an HPV infection yet, that's going to be the most effective. So it makes sense to me that it's covered for young people, but it's undeniably a barrier for sure.
Yeah, for sure. That's fair, and it does make sense. There's always, of course, room for improvement, but it does make sense. So that's the primary prevention. And then regarding the second pillar, we're talking about screening. So there are pap smears and there's a direct HPV screening. Could you talk a little bit about those?
Yeah. So for the longest time, we screened cervical cancer with the pap smear. I'm sure a lot of people listening know what a pap smear is, but for those who don't, a pap smear is taking a sample of superficial cells over your cervix at that transition zone where the cells change from outer skin to more mucosal skin, like I talked about, where the HPV virus likes to infect things. Taking a superficial sample of just cells, so you just take a kind of a gentle brush and brush around that area and put it on a slide traditionally, and that went to a pathologist who looked under the microscope to see some subtle changes in those cells to see if they thought that precancer was happening. And that involves a pelvic exam with a speculum, with a doctor looking at your cervix and taking that smear, that sample of cells. It's not a biopsy, there's no poking involved, but there is a touching of the cervix, and then putting those cells either on a slide, or some are prepared in a liquid and then sent to the pathologist. So that's a pap smear. And it's just looking for the cellular changes of HPV. It's not looking for HPV itself. The other way you can screen is, like you said, HPV primary screening. That's a relatively new thing, although we've known that there's a test that we can use for a long time. I say relatively new because it's relatively new that it's becoming a public health option on a bigger scale. And that just involves a swab in the vagina, in the vicinity of the cervix. Sometimes it's done with a pap test, sometimes it's done with a pelvic exam, with a speculum exam, and sometimes it's not. Sometimes it's just a swab in the vagina, and that gets sent, and they look at a PCR test to look at if the HPV virus is present in that swab sample. And that obviously tells us if you're at risk of developing precancer or cancer in all the manners that we've already talked about.
Great. Okay, thanks, Lauren. So there are these different ways to screen, and like you mentioned, for the longest time, the way it was and the way it still is in many provinces is that routine pap smear. So let's talk about the pap smear. So going in for a pap smear for anybody can be a vulnerable or uncomfortable thing. You have to sort of expose yourself to somebody that you might not or probably don't know well. And that gets complex because for anybody that can be something uncomfortable or something that you don't really want to do. And then for other people who have experienced things like trauma or sexual trauma in the past, that can be especially difficult and it can be a really big barrier. Can you comment on that and what some of the barriers might be to primary screening?
Yeah, so now we're getting into really why cervical cancer and HPV infection and screening, all of these things is a health equity issue, is because the screening programs highlight all the barriers to care in all the underserviced populations that you could ever imagine or think of. It all applies here. So yes, you're absolutely right. Like I said, it involves coming to your healthcare provider once every 3 years is a typical schedule for a pap smear. And putting your feet in stirrups, those cold stirrups that no one likes, and having a pelvic exam, putting a speculum in the vagina. And so, yeah, it's vulnerable, it's uncomfortable. Even, you try as a healthcare provider who's done 1,000,001 pelvic exams like I have, you try to make it as comfortable as possible, talk people through it, explain what you're doing so that anxiety and worries are decreased, but it's still not perfect, especially if you've had a history of trauma or sexual trauma, like you said, or just anxiety and issues around coming to your healthcare provider. Maybe you haven't had a good experience with that healthcare provider for whatever reason. So you have some trauma or worries or anxieties around that, even just coming to talk to them. And then that's the kind of psychological aspect or psychological barrier. That is a huge one. But there's also a physical barrier, right? Like you have to come into the doctor. So if you live in a city and you have a doctor, then great, no problem. You live outside of the city, you don't have a doctor, or you live somewhere where you do have a healthcare provider, but maybe they don't do pelvic exams, or they're not that comfortable at doing them, or you have a bad experience, but there's only one healthcare provider in your community or even nearby, then all of a sudden your physical barrier has mounted, sometimes insurmountably. So that talks about women who are or people who are marginalized, people who live rurally and remotely. All of those people are marginalized and aren't screened or have a huge barrier to screening because of that. So the pap smear does its job. It's a good screening tool, but there's a lot of issues around it for sure.
Mm-hmm. Mm-hmm. Yeah, and that definitely starts to give us an idea of why these marginalized populations are showing higher incidences of cervical cancer on all the studies.
Mm-hmm.
And so there are so many barriers, like you mentioned. There are cultural barriers as well, transportation or logistical barriers. Like you mentioned, you might not have a healthcare provider, they might be far away, booking time off, organizing childcare, and then of course the history of trauma. But regarding that, one positive thing that we can see moving forward is the idea of an at-home HPV screen. So instead
Mm-hmm.
of going in for the routine pap smear every 3 years, and again, I should mention in BC, the guidelines for the pap smears were anybody with a cervix should receive a pap smear from age 25 to 69, I believe, every 3 years. But now BC is actually implementing something new, and the other provinces have also trialed it, I believe. But population wide now in BC, you have the option to opt in for this at-home HPV screening. So, like you mentioned, the HPV swab doesn't have to be done with a pap smear. It doesn't have to be even done in a like a clinic. You can do it at home. So now you can opt in and receive a self-screening kit in the mail. Do your own vaginal swab for HPV, send it in, not have to see anybody about it, and then it's done.
Mm-hmm.
So that's actually happening starting this year on January 29th. Individuals in BC will have the option to opt in for that. So that I think reduces a lot of barriers. What do you think about it?
Yeah, I think it's the coolest thing ever. I'm such a nerd. I think it's so awesome. I actually had was talking to one of my colleagues, and this was when I was still in residency, so at least 2, 3 years ago. And she told me she's now the head of the cervical cancer screening in Nova Scotia, but she also just wrote the Canadian colposcopy and cervical cancer screening guidelines, which was the first Canadian guideline. So she's a pretty big deal. Her name's Carla Willows, and she's awesome. But I remember her telling me when I was in residency that she was like, yeah, I have this friend who lives in the Netherlands, and she did this really cool thing. She had this swab at home and she sent it in, told her she was HPV negative. Wouldn't that be so cool if we had it? Look at that.
Mm.
3 years later, BC's on the board, keeping up with the
Yeah,
Netherlands.
that's great.
Yes, so I think it's a great thing. It's a good test. It's like, so I told you cervical cancer screening with pap smear is good, but HPV screening is even better. So I have a little bit of numbers here for you. So that's for all these statisticians out there, but the sensitivity of HPV testing is 94, almost 95%, whereas with the pap test, it's only 55%. And the
Wow.
specificity of the HPV test is 94%. And with the pap smear, it's 96%. So about the same about the same specificity and even better sensitivity. And there's a lot to unpack there in terms of statistics, which we don't need to get into, and you're going to learn all about that in medical school. But basically, the thing to remember is when you have a screening test, when you're trying to capture absolutely everyone who could be at risk for this disease, you want the sensitivity to be as high as possible. And that's what the HPV test does. So sometimes it's wrong, meaning sometimes it'll say it's positive, but you don't have HPV. But very rarely it's negative, meaning it says you don't have HPV and you actually do.
Yeah.
Right. That's the mistake you don't want to make. You don't want to miss the people who actually have HPV and should come into the doctor.
For
okay.
sure.
So HPV, yeah, the self swab is great. It decreases barriers a lot. And the only kind of hiccup is that you can get this HPV test in the mail. You can do the self swab, send it away. If you're negative, great. 5 years goes by, you do it again. But there is still an issue that leads into inequity of cervical cancer treatment is if your HPV swab is positive, what do we do next? And I think you were going to ask me about that, but I'm just going to jump ahead. So
go ahead. Yeah.
It means that you have to come for something called colposcopy. And every province has a different algorithm for its screening algorithm and how to get patients who are at risk of precancer or cancer into the clinic called colposcopy. You mentioned that in BC, they want to screen patients from age 21 or 25?
25, yeah.
25 to 69. So lots of provinces haven't raised that number yet. They'll start at 21. But most go to 69. Lots of provinces are moving towards that 25 number, especially with HPV, either primary screening or co-screening, meaning doing a pap smear and HPV testing as screening. But then depends on your HPV test result and your pap smear result, whether the recommendation is that you go to colposcopy. So what is colposcopy? It's the Latin word for col is the Latin word for cervix, and scopy meaning looking under the microscope. So that's literally what we do when you come to our clinic. And colposcopy clinics across Canada are run mainly by gynecologists. And that's where you get that skill. So it's not a skill that can be delivered by family doctors or nurse practitioners, which again increases the barrier. Right? It's only specialized gynecologists or gynecologic oncologists. So now all of a sudden you have to go to a clinic that has those people. Those are generally in cities and not closer by your community, maybe. You come in, we do a pelvic exam, same barrier. We put a speculum in, same barrier. We're looking at your cervix. Then we put sometimes some acetic acid on it, aka vinegar, that actually helps us look at cells that look dysplastic or precancerous. And then we look under the microscope to see those cells. We have a various ways to tell if they look like they're really, really bad looking or not so bad looking. And we take biopsies of those that look really, really bad looking to make sure that we're not missing more aggressive precancer or a cancer. And that's the screening part of colposcopy, but colposcopy can also act as a treatment tool. So I talked to you about how else do we prevent cervical cancer. We look for those precancerous changes, and then we do a small procedure to take those precancerous cells off the cervix. And that's called a cervical excision, most commonly now done by a LEEP procedure, which is a little electrified wire that just burns off the top of your cervix. We freeze it. People generally tolerate it really well, but it is a procedure nonetheless that comes with some risks, but the greatest benefit is it's about 80+% effective at taking away those precancerous cells and preventing cervical cancer, even though you've been infected by HPV. So now we're moving past that. Okay, the vaccine, either you didn't get it or it didn't work, but we still have another opportunity to prevent you from getting actual cervical cancer. But again, that whole explanation that I just gave you of colposcopy can be daunting to most people, I would think. I feel comfortable around it, but it's been my life for the past 7+ years. But for a lot of people, man, getting a pelvic exam, biopsies, a procedure, oh my goodness, so I can see how a lot of people would avoid that. With good reason. But I hope that with a little bit of education, and maybe this podcast helps, that we're doing it for a really good reason, because cervical cancer is devastating, and we don't want any part of that if we can prevent it.
Yeah, totally. So even though there are so many points for intervention because of how long cervical cancer takes to develop, like you said, it's important to remember it's not even just as simple as, okay, good, you got your screening done, it's abnormal, go get the treatment, right? Like there's of course many other additional barriers that happen there. So regarding catching cervical cancer early, because we're talking about how we have this long window before things get bad.
Yep.
How early on do you need to catch cervical cancer in order for the treatment to be effective or successful? I know it's not all or nothing, or there's not like a direct cutoff, but just in general, and how important with that is sticking to a regular screening schedule.
Yeah. So I would say it's important to catch it even before it becomes cancer, when it's in that precancerous phase that we call dysplasia. And how important is it? Well, I think it's really important, because you can just outright not have cervical cancer at all, and then your survival is 100%. Whereas if you sometimes we do say it's still a success if we catch cervical cancer in the very early stages. So stage 1, cervical cancer starts as a microscopic cancer, meaning we can't see it with the naked eye, but we can catch it on biopsy at colposcopy, and then we can do a procedure to take it away off the cervix. And then that cure rate is very, very high. But once the horse is out of the barn, as one of my mentors like to say, once it's spread into a macroscopic cancer and certainly spread throughout the tissues of the cervix, with every organ that it touches, it's harder and harder to cure. So very important.
Mm-hmm. Yeah, for sure. And just to go back to the population differences in who's getting cervical cancer. Unfortunately, there is, like you've told me before, there's a bit of a typical presentation for who is getting cervical cancer. And I was wondering if you could paint a bit of a picture for us regarding that.
Yeah, we were talking earlier about that, and we hate to paint everyone with the same brush or call a stereotype or do any of those things. But unfortunately, in the world of cervical cancer, there's often a typical, like you said, a typical presentation because of the risk factors that cause cervical cancer. So I told you earlier that we see women with cervix cancer in their 30s or in their 60s, women with poor immune systems. And the hugest factor that plays into that is smoking. So the vast majority of women that I see that have cervical cancer, or even women who have precancerous changes with HPV infection, are smokers. So the biggest thing that people can do to prevent cervical cancer is to get their HPV vaccine and to stop smoking or never smoke. So those women, like I said, are in their 30s, 60s, they're smokers. And then unfortunately, they're often in underserved population, in marginalized populations, are poor or are in poor socioeconomic status. And that plays into, I can guess at many different reasons why that might be, but it's certainly the typical woman that or person that we do see with cervix cancer. But lack of knowledge and lack of access to vaccination and screening that happens in marginalized populations and poorer populations. More disparities in terms of increased levels of smoking and poor immune systems happen in those populations. And then barriers to screening that we've already talked about happen in those populations. And I suspect a higher level of HPV infection too, for a variety of reasons, although we haven't talked about this, but HPV is very ubiquitous in our population in general, marginalized or not. So I diverge a little bit about your stereotypical question, but I do like to tell all my patients, because many of my patients will say, oh my goodness, this was an HPV infection that caused this. That's a sexually transmitted infection. Who gave that to me, and should I have it treated? And I'm horrified, right? I say to those women, yes, it's a sexually transmitted infection. There's no treatment for HPV itself. You can't do anything to get rid of it. And like I said earlier, it's ubiquitous. So I tend to tell patients that if you've had sex with someone who's had sex with someone else, you have HPV. And that's nothing to be ashamed of. It's nothing to be worried about, but it's something to be cognizant of, that just being a person with a cervix on this planet, I probably have HPV if I've had sex with someone who's had sex with someone else. And so I should be conscious of my cervical cancer prevention strategies, which include vaccination and screening. So I diverge a little bit, but yes, certainly that's my typical patient that I see with cervical cancer.
Mm-hmm. Yeah, no, that's good to remember though, that HPV is such a common virus and it's not selective population wise.
Correct.
It's more so the barriers, psychological or physical or other, that are standing in the way of equitable catching of and prevention and treatment of cervical cancer.
And let me say this too, that this is going to be on my rant of women's health in general.
Mm,
Why is it that this is such a inequitable thing. Why is it that women don't talk about, or people don't talk about, screening for cervical cancer? I get on my soapbox about how women's health issues in general are hidden. They're tucked under the rug. They're not talked about, right? People around the dinner table don't go, "Oh, did you have your pap screen this year? I forgot, I have to have mine, blah, blah, blah." They don't talk about it. Just like they
Yeah.
don't talk about abortion, and they don't talk about miscarriage, and they don't talk about periods that are terrible, and they don't talk about endometriosis. That's an awful disease to live with. I could go on and on and on about women's healthcare issues that aren't talked about because it's taboo for some reason, because that's the way our culture and our society has developed. And so pap screening and cervical cancer screening and HPV infection are the same way. People are ashamed or afraid or just don't talk about it. My mom didn't talk about it, I don't talk about it kind of attitude. And so there's a whole group of people who don't realize that they should get their pap smear, or that they need to get their pap smear, or that they should get their vaccine, or that they should do their, or that they should ask for their home HPV screening, right? The HPV screening self swab is fantastic, but you have to ask for it. You have to know, you have to have that knowledge that that's important when you turn 25 to start doing that every 5 years. If your mom never talked about it at home, and your aunt never talked about it, and whatever, you don't listen to CBC, then how are you supposed to know as a healthy 25-year-old that this is a really important thing to do when you're healthy and you don't need to go to the doctor for any other reason? So I think, yeah, I'll get off my soapbox now about women's health, but that's my rant.
Yeah, no, totally. That's such a good point. There unfortunately is a stigma around so many women's health issues that aren't being talked about enough and need to be talked about more. But on that, what can we do either as healthcare providers or just as community members to, because I think then at the root of it all kind of is just awareness and education. So how can we work on that, and how can we help to get more people talking about this and help to increase the awareness regarding the importance of getting screening and everything like that?
That's an awesome question, and I'm not sure I have an awesome answer. But I don't know, but I think talking about it, right? Talking about it and being more open is important. I just ranted about that. But could we do more as the public health to raise awareness about cervical cancer screening? I think so. I see those posters all around with about bladder cancer screening. You've seen those, like the lemons in the bowl, and one of them's red, and it says, like, if you have red in your pee, you should see your doctor about bladder cancer. It's like, yeah, the same thing for cervical cancer. Can we make posters that are like not cervixes, but we can make pretty things out of cervixes, and have a little bit more of a public health awareness campaign about cervix cancer. I think in my kind of daily community, that happens a lot. There's a cervical cancer awareness month through the International Society of Gynae-Oncology and all of our oncologic societies, but I don't think that's a very public awareness campaign. Whereas breast cancer and getting your mammogram, that's way out there, right? Go pink. But we don't really talk about it when it comes to cervical cancer. And this is a cancer that we can prevent, that we can eradicate from the face of this earth. So yeah, I don't know why, but I'd love to see it out there more in the public. I think that would be important. And I think the vaccine has helped our cause, because that's become a more public topic for conversation, because it's given out to all grade 6 boys and girls in most provinces. So that at least brings it to the dinner table, where parents have to talk about the HPV vaccine with their grade 6 children.
Yeah. Wow. No, that's crazy to think about. I hadn't thought about before, comparing how much of a like public health issue breast cancer is and how much that's talked about. Like, it's everywhere. Versus cervical cancer. Like, most people don't even, well, I feel like so many people don't even know like what is cervical cancer. And yeah, my blood's gonna boil.
It's true though, right? Like a lot of young women know that they have to get their mammogram because they know someone who knows someone who, or saw someone, or did a walk, or a
Totally.
did a
Yeah.
poster or wore a pink shirt one day. And I mean, yes, breast cancer affects more women than cervical cancer. It just as a physically more common cancer. But that doesn't mean cervical cancer doesn't deserve some attention.
Yeah, for sure. Especially because it's so preventable and so
Yep,
treatable if caught early enough.
correct.
Yeah. So there's so much to talk about here, and I think if we had longer, we could definitely get into so much more. But I don't think we need to come to, and we can't come to like a solution. Like, what's the three-step action plan now, right? But we've talked about the importance of education and talking about it more. We've talked about how the HPV at-home self-sampling is positive and is moving us in the direction, even though it doesn't fix all the barriers. It does like debunk a bunch of the barriers. What else can we do? Is there anything we can do to help move this in a positive direction? Or are there any other initiatives you'd like to mention or resources?
Yeah, I will say that from like a more close to home note, as a physician who treats cervical cancer, um, I've talked today about how passionate, and I'm sure that comes across, about how passionate I am about screening and prevention of cervical cancer. Obviously, not one cancer is more sad than the other, but you mentioned, and I mentioned the types of patients that this cancer can affect, patients in low and middle income countries, marginalized populations, but also young patients. So this is a cancer of young women. It happens, that first bump in cervical cancer incidence happens in their early to mid 30s. And that's when women are at their prime and they're having babies. They're starting their family. Family life is starting. And like I will reiterate 100 times that one cancer is not more sad than the other, but it is a difference in a lot of cancers. We see a lot of cancers affecting older populations, and it's just a different manner of treating them and goals and treatment toxicity. But when you're talking about women in their 30s or even in their late 20s who have a devastating cancer that I can't cure. Now, most of the time, luckily, we can treat it and we can cure it. But sometimes they show up on my doorstep and they're really sick and their cancer is really spread fast and far. And the majority of time, and the data supports this, it's because those two first pillars have failed them, right? So either they didn't get their vaccine, or they weren't, or they're old enough that wasn't a school program at the time, or the majority of time, sadly, it's because they didn't come for their pap smear, or they didn't get their HPV screen, or they didn't come to colposcopy to get that early prevention, clearing away of those dysplastic cells. And then they're sitting in my office and I either am talking about chemotherapy or I'm talking about radical surgery to a population who isn't done having their kids yet. And I have to have that conversation and take away their uterus and sometimes their ovaries and their ability to have kids, and just to save their life. And that's really devastating. When, again, we've said this 1 million times on this podcast, but again, when I know it's preventable, the vast majority of the time, it breaks my heart. And it's not to blame, it's not to shame, certainly not, because we've talked about the barriers and why those women might not have been able to get their vaccine or not able to get their cervical cancer screening, and then they end up in my clinic. So I don't have all the answers. I hope we can talk about it more, forums like this, public health forums, kitchen tables, mothers and daughters, women who've gone to their colposcopy appointment and had those precancerous cells cleared away, and it wasn't so bad. their treatment, it wasn't so painful. It wasn't as bad as they thought. They had a good experience. Their healthcare providers were positive and inclusive and supportive. Those stories need to come out, right? Those stories need to be shared more frequently. to encourage people to say, you know what, it's okay. It's not that scary. We can help you through it. And the rewards at the end are really awesome. You've done a great thing for yourself and your family by trying to prevent this awful cancer. So I guess that's some of my final thoughts on the topic.
Mm-hmm. Yeah, I'm not sure even what to say. I just feel like it's so important that we start talking about this more for all of the above reasons. Yeah.
Yeah, I agree.
Well, I hope this has been as interesting for the listeners as it has been for me, and I'm sure that it has. And yeah, we just really wanted to emphasize today how cervical cancer is such an obvious example of how inequitable health measures, preventative and treatment, can shape the populations who are impacted by certain conditions and illnesses when it doesn't have to. If we move in the right directions, it won't. So it's sad that so many people are still getting cervical cancer when it doesn't need to happen if prevention was working as it should. But like we said before, it's also hopeful moving forward, because if we can do these things right, then we can really make a big change. So do you have any, I know you kind of already shared, but do you have any last takeaways or even advice for future doctors?
Yeah. My final thoughts are the vaccine is awesome. It decreases barriers even more than our new awesome HPV self-screening, right? Because if you don't get HPV because you've been vaccinated, then you don't even have to worry about those barriers of getting a pelvic exam and coming to the doctor because you're protected. So my first and biggest message is the vaccine is amazing, and you should talk to your doctor or your healthcare provider if you're in that group of people who has a cervix or not, because men can also benefit from the HPV vaccine, because I told you at the beginning they can contract other HPV related cancers. So if you're in that group of people who has not been vaccinated for whatever reason, it doesn't matter your age. It's still worthwhile having that conversation with your doctor or your healthcare provider about the potential benefits to the vaccine for you. So that's one of my messages. My other message to future doctors and healthcare providers who might be listening to this is women's health is really important and really under-recognized as an important pillar in our healthcare system. Women represent a huge, important cogwheel in our cultural and social development, and taking care of women makes the world 100,000% better faster. And I'm really passionate about that. So approaching women's health with an open mind and a caring heart is important. No matter what kind of doctor you become, women will be in your circle of care. And so taking that opportunity in med school and the early days of residency or clerkship or whatever healthcare training might come your way, to learn how to do things like a sensitive exam for a woman, whether that's a breast exam or a pelvic exam. I think every healthcare provider can benefit from that knowledge and that education for all the reasons that we talked about today and the barriers today. It doesn't just apply to cervical cancer, it applies to many women's health issues. So if you come across a mentor who you think pardon me, is excellent at delivering culturally safe and trauma-free, informed care for women and exams, then latch on to that person, ask them a million questions, take it on, and try to embody some of that awesomeness, because it'll go a long way in your health career.
Amazing. Thank you so much, Lauren, for taking the time to chat with me today on such an important topic.
No worries. Thanks for having me.
Thanks for tuning into Just Medicine today. I really hope you enjoyed the episode, and be sure to keep your eyes and ears peeled as we've got a lot of other exciting episodes on the way. Until next time.